So I really would welcome views, questions, comments to any of the panel, but to each other as well. So if we could ask for questions or comments. Lady there, please.
Just a comment really on changing kind of culture around involving family and relatives in patients in hospital. Recently spent lots of time in hospital, always had a challenge with staff about staying to care for that relative. And things that I kind of see in hospitals more recently is protected meal times, with a view that actually patients need to have that time, to have protected time. And I sat in a ward with 5 elderly ladies who waited for a long time to have that assistance to help with their meal. And I think there's, the kind of changing that whole culture where relatives may be able to be encouraged to support those particular patients who need that help. And that kind of, patients, nurses and staff seeing that relatives are not there as a support, can be there as a support and have a very valuable. And I don't think that's easy to achieve at all. On a personal level, as a clinician, I've had some major challenges on that kind of. So how we change that culture, where we can support each other and look after patients together.
Raj?
I think colleagues right, it's really difficult to achieve the change in culture. But once it gets going, it spreads like fire. Because clinical teams are not slow in seeing the benefits to their patients, and they're there for their patients. I'll give you an example. We have a really large ITU, it's 42 beds, and to get into ITU, it's like getting into Fort Knox. Even my passes don't get me all the way through into ITU. And just recently, an intensivist told me a story about patients. It was really confused. The patient was really confused, and they had spent an hour and a half trying to calm the patient, and the patient was still intubated. And a staff nurse went out to the visiting room and got the patient's wife and brought the patient's wife into ITU. And within a couple of minutes, the patient's wife calmed the patient down. And he just said, and he's a long-standing intensivist, he says, why haven't I done this before? So where we're at now with that intensive care unit, we're going to open those locked doors are now unlocked. We're going to have open visiting. And it still has to be managed, because of the nature of the event. But visitors, patients and families aren't visitors families aren't visitors to the patients. We're the visitors. We're trying to change that around. And so you do it by leading through example. You've heard me talk today, and when I talk about patients, I talk about patients and families, and it's really important for the leadership teams to talk about patients and families rather than just the patient. And I think also an advantage is that all of our clinical teams will see themselves as being very patient-centric, and the majority are. But this patient and family concept is something new to them, and they see the difference and they see the potential value because it's something new. So rather than just talking about being patient-centric, which we could, talk about by talking about patients and families, they're saying, well, there's something new here that I might want to get interested in. So is it universal across my hospital? It's in about 10% of the hospital so far, but we can see it spread and spread and spread.
And Raj, what's the mechanism by which, if that is that good as you say it is, and we don't doubt it, how do we get it to the Royal Liverpool Hospital, St Helens and Knowsley, right across the patch? I was in discussion with Helen Bevan and her team about starting off a call to action on patient and family friendliness. And I think it's going to be a social movement approach, illustrating the benefits both to patients and families and to the staff. So that's possibly one way that's going to go out. One of the things we talked about yesterday is we've got some good ideas of what we want to do, and I asked and challenged Muir Gray, how do we do it? We know what to do, but how do you do it? And it's becoming a recurrent theme now. It was about empowering patients, and you get the patients on your side, and that's just another example of empowering patients. So when we want to effect change, you educate and empower the patients, and they will help us do it. Well, they're doing it for themselves, effectively. Tony?
Thank you. Actually, David, I think you've posed my question, which was this. You've clearly got a very compelling example in your force reduction programme. You've clearly spread it within your trust. How can you reassure me and others in this room that if in 10 years' time we're sitting in a similar conference, we're hearing some chief executive talk about a force reduction programme as some new idea? I mean, how are you going to persuade us that this can be adopted widely right across the NHS, because it's clearly very cost effective. It's not costing you very much money if the family members are involved. But how are we going to ensure that it's spread right across the NHS rather than be invented 25 times in the next 25 years?
It's a great question.
I think that is actually the key question of what we're about. So we've got to bottom that question out, and let's try and do that between us. Raj and then...
Well, I'll very quickly, it'd be, why wouldn't you do it?
It's about how, though.
But spreading it...
Yeah.
How did I get switched onto it? I got switched onto it by reading an article and then talking about it with the clinical teams. And then we went off to the States to see something happen. Now, we can't send everybody off to the States, but most certainly how we've set fire to the organisation with this is by giving example after example and the leadership team going. And that same principle can apply to right across the NHS.
Yep. Roger?
No, can I just build on this theme, because as you said, that is at the heart of this discussion today, isn't it? And what I wanted to do was do two tests with you, yeah? Firstly, on a scale of 0 to 10, can you raise your hand? Tell me, where are you in terms of motivated? How motivated do you feel about innovation on a scale of 0 to 10? Are you on the 0 side or are you on the 10 side? 10 side?
8.
8? Okay. Now, put your hands up. Same scale. Second question. How confident are you that you can make a big difference? 0 to 10. 0? 8. 8? Yeah, that's actually pretty good, isn't it? So that actually is encouraging, that people feel confident that they can overcome these challenges, which goes back to the question that was being raised. So the point I've got to make is now coming around to answering that question itself. But what specific things we could do so that we can take that message back to Jim Easton? What is it that is stopping us? Because my question would have been the same as the one that Tony asked. Why isn't it spreading fast enough? What is that we have to unlock? And if we just keep saying that it's going to be culture and we're going to do it on a team by team basis, we'll be here for next 15 decades.
Yeah.
We need to speed that up.
Look, I mean, I think one of the problems is because there isn't a system, we do it very well on a piecemeal and opportunistic manner, just like Raj has done. And there are lots and lots of things like that. But there isn't a system that picks it up and puts it in. So we've actually got the power to do that for the Northwest. We can't do it on a UK basis, but we have got, so maybe what we've got to do, and perhaps we'll get a comment on this in a moment, is set up the system by which you disseminate innovation, and we've got an idea about that. Nick?
Well, I'm just going to make two points, and I'm sorry, I'm probably a very poor replacement for Jim Easton, because it was part of the question I was going to ask him.
You can answer your own question.
Well, we've heard over the last day and a bit some really good examples of things that are happening, and there was a very good example yesterday in one of the workshops I went to where one particular area is really rolling things out in a fairly significant way, and they've changed processes, but they want to keep it secret from the point of view of not suddenly having the QIP people getting on the bandwagon and it's suddenly becoming a performance manager driven process. So there's a real dilemma I think we've got, and I think the first thing I would say to you is you really collectively ought to try and put some key points to him as the lead for QIP, which will bring about significant change, how that can be made seen as a positive process rather than, oh my God, it's a whole series of other targets and measures that we've got to meet. And the second thing, which I think is more for yourselves, is the future of HIACs, if they have a future, will be whether you convince the employers that you can do this spread and diffusion. So if you can't convince Raj or any other chief executive, whether it's on falls or whether it's on other things, that because of your collaborative approach, because the HIAC is made up of all those constituencies, surely you've got the levers to actually say, well, if they've done it in this hospital or in this primary care area, we can roll it out wider. That's how you'll get the spread.
And show the advantage to that organisation.
Yeah.
You know, that's what will get...
Which is a dilemma, because you're not going to prove to the chief execs or nationally that you can do things unless you show the evidence, and the fear is that once you show the evidence, it'll suddenly get taken out of your hands and it won't become the constructive process.
It was really just to build on Nick's last point. We've got to get the hard wiring right to make this happen. And are there any commissioners in the room? So, from a commissioning point of view, a comment I made in my presentation was about Knowsley PCT and the bravery that they showed in commissioning the service. Because a really important part of the contract was the fact that they set out a quality indicator that said something like, if you have an MI, our job of the job of the providers was to get 85% of those patients back into work, if they were in work, within a 3-month period. That's a very, very different metric to saying, activity count to OPD or elective interventions, or even some of the qualitative indicators around infection or whatever. It said, what is the true outcome that we're working towards? Commissioners have to be brave in that, because that's quite a...
But I guess from the HIAC's point of view, it ought to be us going to persuade the commissioners. So the response I would give to Tony's key question would be, what is it we do that would persuade commissioners or chief execs to do it differently? And what's evolved in my mind over the last 24 hours would be this concept of empowering patients. That's number one. So education and empowerment of patients. Number two is having good evidence and good data. So this Michael Rawlings, we were actually talking about education. The nice data coming down should be the way you treat patients. But your evidence about the drop in falls or whatever, that is such good evidence, it's hard to argue against that. And then the other two bits was, one was about the next bit, so it was empower patients, the good evidence, this concept of getting them while they're young, so empowering the young people in our system, they're going to be the future. And I actually think we need to have some incentivization as well, so that the money follows good practice. So you have no perverse incentives like we were describing, let's keep it secret because it'll do something. So you've got to set up the incentives that they actually drive innovation. There's our panel.
Thanks, David. Arpan Guha, I'm a Cheshire Mersey High Board member. I just thought that it would be an opportunity to actually highlight something that we have agreed recently on our patch, which is actually to create an innovations hub, which basically will take in the kinds of innovations that are already in place. I often, in fact, at the last meeting, I referred to the LHCH superb care bundle in the placement of invasive monitoring lines, which has been shown to reduce hospital-acquired infection tremendously. And I think the HIACs are very well placed to actually sort of diffuse that across the patch very, very rapidly. And that's a key indicator, obviously. The other benefits of how it's constituted, it's actually very well placed to actually know what are the clinical problems across a patch? What is the problem with diabetes? What is the problem with COPD, etc., and do that diffusion very rapidly. And I think that would fulfill the implementation aspect, which I think everybody said that there is no problem with innovation in the NHS. The problem sometimes is the dissemination and the implementation of that. And I think we're very well placed to do that.
Thank you. And I think if we manage to set up that hub successfully, I mean, this should be then to a northwest basis, and then we've got colleagues from Newcastle here. There's no reason why this can't spread across our new cluster. I'm not going to go as far as saying we'll spread it down to London yet, but if we do well, Cheshire and Mersey, but if we can get it across the northwest and across the northern cluster, you've got a result there. So what you're describing is how we set up the system to get this out there, and I think that's got to be our next step, is to set up that system.
So I was revisiting your earlier list. I think it'll be useful to capture those points. You start by empowerment, evidence, and the youth, etc. And I'm going to say something which may seem like contradiction in terms, but it is actually making innovation mandatory. Let me explain what I mean by that. Yeah? This is a conversation some of us are having yesterday in another group, and it came from the idea of never events. Yeah? We all know about never events. And we started talking about, well, why don't we have the other side of it, is ever events? Yeah? Something everybody should do. So in terms of the spread and acceleration, we can obviously work on those levers, and I'll say that some of those levers are necessary, but they're soft levers and they're long-term levers. What we don't have is the luxury, because to paraphrase Jim, innovate or die. Yeah. That's what he was saying.
Scholars, that is a challenge from Rajan. How do we do that? So we'll let your young minds work out how we take forward the concept of ever events then. You've given that homework for them.
Okay, there you go. Sorry, guys.
Okay, there's a question at the back.
Good morning, I'm Cass, I'm one of the Medical Leadership Fellows. My question is in regards to the release of information to the public domain and transparency, which I do believe in, but have you considered the negative consequences of that? Sometimes giving quite simple data to complex situations can bring about negative impact to the public, and especially in society that we're living in at the moment, which has huge media pressures. Is it the most sensible thing to do?
Raj,
review.
Part of our role as healthcare professionals is the management of risk. Absolutely. And that's about the information and about the handling of the risk with that information.
Absolutely. The data I put up there has been validated. Each unit is checked out for themselves, and it's pretty robust. Talking about the cancer tumour group data. I personally cannot see the risk in putting that information out as long as it's put out in a careful and considered way. Because those units that were on your right-hand side, the ones with the high complication rates, have been doing that for years. What is going to change? What's going to force the practice? Those patients who are in that unit on the right are going to be really worried, aren't they? And we have to manage that expectation. But I've reached a point in time now where I understand it's a complex situation. I understand the risk about putting information out there. As long as it's validated, it's pretty robust, it should be in the public domain. Who are we to say, and who are we to be so paternalistic to say our public won't understand what that information is about?
Just to go on with that as well, I completely agree. It's got to be out in the public domain. It's got to be usable to the user, though. And there was a great example of this yesterday with Sir Michael Rawlings. You imagine all the data he's got in his head. He made it dead simple. So his presentation, as he was just getting the information out, he just sat there and it was easy to understand. So if we are going to put the information out, it has to be, get rid of all your p-values and that sort of stuff. It's got to be easily understandable. And that was the point that Sir Michael was making yesterday.
Keith Chandler from the Northwest Innovation Hub. Clearly, as we move towards the clinical commissioning groups, they've got a tremendous opportunity and tremendous power to push innovation across the system. What plans are in place to start to engage with them? How can we engage with those CCGs as they start to form up? So innovation's in there as part of the core duty from the start.
It's the engagement with the CCGs, not just in that issue, it's in general, because I only know about Cheshire and Mersey, they're not well enough formed yet. You don't even know who to pick up the telephone and speak to at the moment, so we've got to see how they do form, And then we've got to develop communication links. It's about, I don't know if others have got comments on that.
Very similar view from me, David. It's early days for CCGs. The pressure on their time is not going to be around innovation first. They'll be faced with budgetary and other pressures, and they'll get to innovations last unless we do something about it early on.
But I think we need to get in there.
Absolutely.
They could forget education and training.
Absolutely.
So my plan is to get them straight away and get them involved in. They're represented on the LETB. So formally, that would be the way it would happen. Nick?
Well, I was just going to build on that. I mean, both at a national level and locally within the new workforce framework, I think there's a real intent and desire that the CCGs, the service commissioners, have to be very involved in the workforce education, so that it isn't just, well, that's the provider's responsibility because that's where the staff are. If they're going to change service, and significant change to service, they've got to have an understanding of the type of workforce that's going to be needed and have a good engaged discussion with providers on that.
Yeah. And the impressions I've got, I've talked to our, several GPs, and they are up for this. So it's there. We're just going to have to help them with all the other things they've got in their mind. Raja, and then I'll let you come back.
Okay. Bear with me. I'm thinking a lot about this, and I may come across as rude. But the point here is that I think we need to actually start thinking differently. And the reason I say that is, I don't know how many of you were at the dinner with Roy Lilly yesterday when he drew the organogram, it turned out to be Jackson Pollock painting. When he actually showed us what the landscape will look like from the DS to commissioning board to CCGs and clinical senates. You remember that diagram? Mm-hmm. Some of you, yeah? And the point I'm making is that I think we should not wait for the system to be set up and start delivering, because it probably won't stand still anyway. But more importantly, what has come out for me from the conversations yesterday is that we need to create more of a social movement here. Let's not actually always think about how do we work through organized systems. What we need to do is to fire up people individually. And what I will be wanting to do is, in my own badge, is to try and identify these key opinion makers, these champions, the future leaders, and start getting them involved in these discussions and create a different type of movement whereby we don't wait for this clinical commissioning group to be set up or centers to be set up. We actually make sure that these people are ready to start influencing their agenda. And I think that is where this innovation spread will happen, not through formal organized systems.
Stand innovation. If I clap as well, then you can't stand innovation. Absolutely agree with you, and we do need the champions, and that's where innovation comes from the champions. But we've got to use the system as well. And yeah, they are very busy, the GPs, as they're starting to set up these new things. But if we don't get innovation in their list of things to do at the outset, we'll end up trying to force it in what will be a very busy agenda. And I read through the authorisation processes and the tasks for the CCGs the other day. It came out from David Nicholson. Unless I've missed it, the word innovation actually isn't in the whole document of the tasks that are set out for the CCGs. Research is in there, not R&D. Research is in there, and that's mentioned in quite a few areas. And they can have no doubt that they have a responsibility for research. And QIP is in there, but I can't find it innovation. But Nick may prove me wrong.
Remember what Jim Easton has said today. He wants to hear from this conference. He knows this is what's happening on the ground. We'll tell him that. And he's there with David Nicholson, who's producing his paper on innovation in the next few weeks. So that's an opportunity to get it in. Nick?
It's a bit of a challenge back, because one of the things that slightly worries me is research is in there but innovation isn't. And I think where the HIACs are about and what their essence is spread and adoption. Innovation is only one element. The fact of the matter is there's best practice that goes on in some units but not in others. So it's much broader than innovation. Innovation's clearly important, but actually it's about, are we providing the best value and way in which we can do things? So research will have done their bit, there'll be innovation, there's best practice. This is about how do we get all of that and actually make it best value for the organisation.
And that best practice is there at the moment.
Yeah.
We just need to get it. We just need to pull it in and get it out there. You know, as we've heard from Raj today.
Cathy O'Sullivan, Thames Valley Hayek. We are working with clinical commissioning groups in Thames Valley Hayek. We've got 5 different projects happening. Our experience is the CCGs, the emergent new, very new CCGs, are hungry for help. They need the help now. They're not really terribly interested in the managerial aspects of the authorisation process, the governance, the finances. That's just a mechanism for improving patient services. And like everybody else, they're hungry to improve patient services. I think the Hayeks are uniquely placed, actually, to help with the relationship building. So I'd like to urge you in the Northwest to help them now. I think they need it now. Don't wait till they're set up and they're official and they're mandated, because they're only doing it to improve patient services like all the rest of us.
Yeah, I absolutely agree, and well done. It's nice to hear views from down south. I'm actually, the problem is, because the groups aren't formed, I'm having to speak to GPs before they are on the board of that group. So they're all up for it, and that's the impression I get. They really want this, and they say, let's not lose, they want help, let's not lose education and training, innovation, the whole lot. So I think right across our patch, that's the approach we have to take with nascent organisations, not well formed, but what the hell, just get on with it anyway, which is what you're suggesting. So thanks for that. Another, yep.
Hi, my name's Sarah Hughes. I'm another interloper from the south and on the dark side of commissioning. A couple of observations, really. One was just to pick on something that Nick said. I don't know whether you were in the session I was in, which was with Alison Wheeler on large-scale change. Yeah. Because that's exactly my experience. It's been that when I've tried to innovate with my partners and providers, it gets picked up as quip and dragged into the PMO, the project management office, and immediately I've got all these performance targets that I've got to meet. So I think that kind of feedback to Jim would be good. The other
probably feedback and how he might
do it differently,
make the process positive.
Absolutely, because quip has just become an analogy for financing performance targets, certainly in our economy, in our local community. I think the other thing was our CCG is well engaged with our local providers in secondary care, and we had what was kind of similar to the early thinking around clinical senates, and we were beginning to talk about kind of joint clinical commissioning models. And what's got in the way a little bit has been the market, because some of these consultants from secondary care were spending a lot of time with us on reviewing pathways and thinking about doing things differently. And then it kind of dawned on them that we might go and commission some of that care from somewhere else, and they've withdrawn because they're saying, well, why would we spend all this time, all this energy, and invest, this, in intellectual property, if you like, in this, and then you may go over the border, or you may go to another independent provider. So that's just been relatively recent for me, and just an interesting
that's really worrying, because you need your local experts to design the diabetes pathway or whatever. Absolutely. How are you going to get them back? That's really worrying to me. That.
Yeah. So I'm just getting this sense of risk from the providers that why would we engage if you're then going to go off and commission it from somewhere else?
Don't commission it from somewhere else. Commission it from the NHS. That's what I would say without hesitation. Sorry about that. Christine?
I just wanted to make, I think, probably a very obvious point, but I'm not sure I've really heard it over the course of these 2 days. And it's about investing and freeing up clinical time, because it seems to me that in the main it's going to be clinicians and frontline clinicians that are coming up with the ideas, but also really need to be involved in spreading that across their professional networks and engaging clinician to clinician. And then certainly in my experience, the times when it's worked well, both in terms of getting the thing that works, responding to the problem, and then actually transferring it across. I mean, yes, managers can help with the, working through the system and getting them money and blah, 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 but it is actually the clinicians of whatever type and variety that I think make the difference, and I think we need to bear that in mind a bit more.
I think that's really important. I mean, it's talking about all healthcare clinicians. I'm going to ask Raj to comment on that, because this is about clinicians who are busy running the service. How do we pull them out to do this? It's the here and now versus planning for the future.
Colleagues, I agree with colleagues mostly, but I'd also emphasise the importance of good quality management and achieving sustainable change and delivering that. In my experience, it's been where you've had the combination of a clinician who's got some really good time and obviously the talent to solve the problems, coupled with really good management that's delivered the change. That was the example in cardiovascular services. It's the two together.
The other bit I'd add into that, but it's becoming a recurrent theme, I get the enthusiasm of youth there, and you'd actually get our doctors, nurses, etc. in training. They're going to do it for their future. I'd get them in there because they come up with good ideas, and if you do something daft, they'll tell you about it. For sure.
I had a really, in one of our sessions yesterday, and I'm not sure if she's still here, in the research session, if you asked a question that I suggested we put to the panel, which can't be here, so in which case I'll do it, saying that it's really quite concerning in the research arena where they have patient groups who are absolutely committed to try and finding ways of getting that message out and getting it through research and the RFPB bids. And when they try and get clinicians on board, because it hasn't been their clinical idea, and because they haven't been, they're actually saying, I don't want to be the PI for that. I don't want to do it. It's not mine. And I wonder, in that whole system, as much as we need to make time for that, I think there does need to be a challenge to organisations to have a culture whereby, if your clinicians are not intent on doing it and engaging with those things, what is it that we are doing to make sure that we are employing or supporting those staff with the right culture of engagement with patients and actually taking on what is useful for them, for the patients, rather than necessarily what is interesting from them, from their clinical background or from their expertise. So that's a question that came from one of the research sessions yesterday, which is important for the culture.
I think we have to be pragmatic. The community cardiovascular service that we ran, when that was initially talked about in my hospital, which is in essence a tertiary hospital, there was a good group of clinicians who said, over my dead body will I go out into the community, because they sat there in the ivory tower. Well, we did walk over their dead bodies, and and what we did was, Dave's point, leverage youth. Clinicians who had 15 years left of their career or more were the ones who were keen on it, because they could see the future and they could see how the future was going to change. So pragmatism, go with the early adopters, go with people who are going to be keen to work on the agenda.